Well, we are moving now to a more clinical session, and my topic will deal with clinical features, screening, and diagnosis. This is my disclosure. Well, regarding
Professor Valensi, sorry,
yes?
Can you make slideshow, please?
I try, but unfortunately, I can manage. Sorry, maybe I
once again.
Try, yes, once again. I have something at the bottom, impossible to get the full screen. Well, I will try maybe later.
Okay.
Well, regarding DPN, we heard from the first speaker about the high prevalence of this complication of diabetes. And of course, polyneuropathy accounts for increased morbidity, also increased risk of mortality, reduced quality of life, and increased healthcare costs. Painful diabetic peripheral neuropathy affects some 13 to 26% of diabetic patients, depending on the settings, but up to 50% of patients with DPN may be asymptomatic. So DPN is still not adequately diagnosed and treated. And we also heard about the multiple targets of neuropathy, which may affect both large and small fibers. This slide shows a summary of the recommendation from an international expert consensus. We can see on the left part neuropathic symptoms and how important it is to question patients about pain, about non-painful symptoms that they may complain of. And of course, we can try and quantify these symptoms using scores. On the right part, we have deficits which may concern small fibers, including loss of sensation of using pinprick tests, and also loss of temperature sensation. This is for small fibers, and for large fibers, vibration sensation thresholds are impaired, and also abnormal ankle reflexes, proprioceptions, and pressure sensation may be impaired. And for all of these symptoms and deficits, which we may quantify and make what is called quantitative sensory testing. Now, regarding cardiac autonomic neuropathy, we performed this study several years ago and showed that in a population with type 1 or type 2 diabetes, the prevalence of cardiac autonomic neuropathy based on cardiovascular tests, I will go back to this later on, the prevalence of cardiac autonomic neuropathy was high, around 20% in type 1 and around 15% in type 2. MCAN is associated with an impaired prognosis with an increase in cardiovascular outcomes in patients with diabetes. What about the assessment of cardiac autonomic neuropathy? This is based, and it's an international consensus, on heart rate variation measurements during standard tests, which are deep breathing tests, Valsalva maneuver, lying to standing tests. And it's important to take age into account when analyzing the results. These tests assess mostly cardiac vagal activity. Also, in the Toronto consensus, we agreed on three stages for CAN, possible or early, based on one abnormal cardiovagal test, definite on or confirmed CAN, based on at least two abnormal cardiovagal tests, and severe or advanced, based on the presence of postural hypotension together with abnormal cardiovagal tests. And CAN has some important determinants. The established risk factors for CAN are glycemic control in type 1 diabetes, and in fact, in type 2 diabetes, CAN is probably the result of several disorders, including hypertension, dyslipidemia, obesity, and also glycemic control. Also, CAN is shown to be associated with microvascular complications, including peripheral neuropathy, but this is not univocal, I would say, across the studies. Association also with retinopathy and nephropathy. Now, I'd like to share with you some data we recently got in our department. The aim of this study was to analyze the relationship between peripheral neuropathy as detected by nerve check master on one part, or detected on the Michigan Neuropathy Screening Instrument, MNSI, on another side. And in the same patients, we assess CAN using the standard test. And this was done in patients with type 1 or type 2 diabetes. So this is a reminder about the nerve check master, which assesses perception thresholds for vibrations, for warm, cold, and pain sensation. And nerve check master was shown to offer good performances for the detection of DPN. At this stage, we included some 76 patients with type 1 diabetes, 65 patients with type 2. Patients with type 2 were older, as expected. Diabetes duration was roughly similar in the two groups. BMI, as expected, was higher in patients with type 2 diabetes, and mean A1C was around 8% in the two groups. Well, regarding nerve check master, as I mentioned, we have here the four sensitivities we test, and we can consider that peripheral neuropathy is present when at least two tests were abnormal among the four tests. And also, we use the Michigan Neuropathy Screening Instrument, this simple test, which includes the appearance of feet, presence or absence of ulceration, ankle reflexes, vibration perception, and monofilament. And DPN was considered to be present if MNSI was equal to or higher than 2.5 on the scale of 10. CAN was assessed, as I mentioned, including the three tests for heart rate variations and postural hypotension, and we considered CAN to be present if the patients had at least two abnormal tests. Now to the results. Here is shown the prevalence for each test in patients with type 1 or type 2 diabetes. We can see that vibration perception threshold was abnormal in a lot of patients, 67% or 83%, arthritis type 2 patients. Also, around 50% had a normal threshold for warm perception, and heat pain threshold was abnormal in a lot of patients. Now, if we consider two abnormal tests when using the nerve check master, we had around 60% of patients with type 1 and 70% of patients with type 2 who had evidence for peripheral neuropathy. When using MNSI, the prevalence was far lower, 26% in type 1, 35% in type 2. So far more patients are detected with peripheral neuropathy when using NCM. And regarding CAN was present in 22% of type 1 and 2 more times among patients with type 2 diabetes. And now the most important result, which is to put together the results of detection of peripheral neuropathy with the detection of CAN. On the left part, we can see the number of patients with CAN among those with NCM+, therefore with evidence of peripheral neuropathy. So 1/3 of the patients, of the type 1 patients with peripheral neuropathy had CAN, against only 3% of patients who were free of peripheral neuropathy based on NCM. And the difference, of course, is quite significant. On the contrary, in type 2 population, the prevalence of CAN was roughly similar or not significantly different when considering the patients with or without peripheral neuropathy. So we can estimate the performances of NCM for the identification of patients with CAN among type 1 and type 2s. In type 1 patients, the performances seem better as compared to type 2. And the most important results is in red, showing that the negative predictive value of NCM for CAN is 96%, which means that when NCM does not detect peripheral neuropathy, we are nearly sure the patient doesn't have CAN. And now if we perform the same analysis when considering the detection of peripheral neuropathy using the MNSI, we don't have any significant difference, which means roughly the same prevalence of CAN among the patients with peripheral neuropathy, considering the results of MNSI or without peripheral neuropathy. So I'd like to conclude saying that, well, again, the prevalence of DPN according to NCM is higher than considering MNSI results, and this is maybe interpreted, of course, as regard of the detection of an impairment of both large and small fibers when using NCM. In patients with type 1 diabetes, the presence of DPN, according to Nerve Check Master, is able to detect almost all the patients with CAN. And of course, when you are suspecting CAN, you need secondarily to investigate the patients using specific tests. While the absence of DPN according to NCM excludes the presence of CAN. So this may be important in clinical practice. This data is consistent with a combined impairment of small nerve fibers, small peripheral fibers, and autonomic fibers. But this finding does not apply to patients with type 2 diabetes. MNSI accounts weakly for small fibers impairment and is not efficient to detect patients with CAN. And now, how to interpret these findings? We can say that the lack of association between DPN and CAN in patients with type 2 diabetes is consistent with a plurifactorial pathophysiology of CAN in these patients, which involves other factors in addition to long-term hyperglycemia. And on that, I will end and thank you for your attention. And of course, I'm ready to collect comments and try to answer questions. Thank you.